Hi all, I'm Dr. Malati, working as a professor in Tripura College of Nursing. In this video, I'm going to discuss about the menstrual abnormalities. The objectives are introduction, definition, types, amenorrhea and dysmenorrhea, oligomenorrhea, abnormal uterine bleeding, menorrhagia, intermenstrual bleeding, summary and conclusion. Introduction. Menstrual irregularities or the abnormalities in the normal menstrual cycle involving the changes in the frequency, duration, amount of bleeding or timing of menstruation. So, a normal menstrual cycle will last for 21 to 35 days with menstrual bleeding lasting between 2 to 7 days. So, here the irregularities denotes or else it may be due to the hormonal imbalances, pregnancy, stress, nutritional deficiencies, endocrine disorders, infections, medications, or diseases affecting the reproductive system. So the common menstrual irregularities includes amenorrhea, dysmenorrhea, menorrhagia, oligomenorrhea, polymenorrhea, and metorrhagia. Here, the early identification and appropriate management are essential to prevent the complications such as anemia, infertility, and also to improve the quality of life. So in this condition, the nurses has to play a vital role in assessment, health education, counseling and supporting the women with menstrual disorders. Next, coming on to the definition, menstrual irregularities are the common abnormalities for a woman's cycle. Menstrual irregularities includes a variety of conditions in which menstruation is irregular, heavy, sometimes it may be painful or does not occur at all. The types of menstrual irregularities are amenorrhea, dysmenorrhea, menorrhagia, oligomenorrhea, polymenorrhea, premenstrual syndrome, menopause, metorrhagia, dysfunctional uterine bleeding. First is amenorrhea. So amenorrhea means which is nothing but the absence of menstruation, and it is not a symptom, it is a disease. So amenorrhea occurs mainly due to the five basic factors. Mainly it involves in the onset and continuation of the normal menstruation. So here the five basic factors are normal female chromosomal pattern, that is 46 excess, then coordinate hypothalamus pituitary ovarian axis. Third one is anatomical presence and patency of the outflow tract. Fourth is responsive endometrium, and the fifth one is active support of thyroid and adrenal glands. So these are the main five basic factors which involved in the onset and continuation of the normal menstruation. If there is any effect in all these or else in any one of these basic factors, usually menstrual irregularities occurs. The clinical types in amenorrhea are two types, physiological and pathological. So physiological usually primary, which is nothing but the thing which occurs before puberty. Secondary is during pregnancy, during lactation and following menopause. Pathological, which is nothing but a concealed one, we will be calling it as cryptomenorrhea, congenital, acquired, primary and secondary. So these are the clinical types which comes under the amenorrhea. First clinical type is primary amenorrhea. A young girl who has not yet menstruated, even if she is in 16 years of age, we'll be calling it as a primary amenorrhea rather than the delayed menarche. So here, according to the WHO, they have mentioned that normal upper age limit for attaining menarche is 15 years. The causes are, first one is hypogonadotrophic hypogonadism. So this causes may occur due to the delayed puberty, delayed GnRH pulse reactivations, then hypothalamic and pituitary dysfunctions, Halman syndrome, which is nothing but an inadequate GnRH pulse secretions, which may lead to reduced FSH and LH. So FSH is just nothing but a follicle stimulating hormone and luteinizing hormone. Then CNS tumors, then craniopharyngioma. These two things may lead to reduce GnRH, gonadotropin releasing hormone. So that will lead to reduce secretion of the follicle stimulating hormone and the luteinizing hormone. Second cause is hypergonadotrophic hypogonadism. May occur due to primary ovarian follicle, resistant ovarian syndrome, galactosemia, enzyme deficiencies, that is 17 alpha hydroxylase deficiency, and others are gonadotrophin receptors mutations. Third cause is abnormal chromosomal pattern. That is Turner syndrome, which is nothing but 45X. Then pure gonadal dysgenesis, which is nothing but 46Xs or 46XY. Next is androgen insensitivity syndrome, testicular feminization syndrome, we will call it as. Then partial deletion of X chromosome, that is 46XX. Then the fourth cause is developmental defect of genital tract. May leads to the imperfect hymen, transverse vaginal septum, atresia upper third of vagina and cervix, then complete absence of vagina. Coming on to the classification of primary amenorrhea. So primary amenorrhea, it is classified into three main types, that is hypergonadotrophic, egonadotrophic, hypogonadotrophic. First type is hypergonadotrophic primary amenorrhea. So it includes abnormal sex hormones, that is gonadal dysgenesis, 45, external syndrome, mosaics, and abnormal X. Second type is normal sex hormones, that is 46XS pure gonadal dysgenesis, 46XY gonadal dysgenesis, you can call it as stress syndrome. Then the third one is a gonadotropin resistant ovary syndrome, Savage syndrome. Second type under primary amenorrhea is egonadotrophic. So here it occurs due to Mullerian development. So under this it has two main types, that is androgen insensitivity syndrome, we'll call it as a testicular feminization. Second is Mullerian agenesis, which may lead to absence of uterus or vagina. Second one is normal Mullerian development, female or true intersex. Second type is polycystic ovary syndrome, adrenal or thyroid diseases. Third one is cryptomenorrhea, which may lead to imperfect hymen and vaginal septum. Third type is hypogonadotrophic primary amenorrhea. So under this, it has a classification. First one is the hypothalamic causes, that is delayed. So due to this hypothalamic causes, it may lead to delayed menarche, hypothalamic hypogonadism, psychogenic or weight loss. Second may be due to the pituitary causes. It leads to neoplasm, hypopituitary states. Third one is severe systemic diseases like tuberculosis. Coming on to the management of primary amenorrhea for hypergonadotrophic primary amenorrhea. So this is the first classification which comes under the primary amenorrhea. So here the patients have gonadal failure. So various form of gonadal dysgenesis account for these cases. So these women have streak ovaries with the absence of ovarian follicles. So there is no estrogen production at all, and they have an elevated levels of follicular stimulating hormone and low estradiol levels. Women with streak ovaries are leads to infertile, but they can bear children with oocyte donations. So all women in this group must be treated with cyclic estrogen and progesterone to promote the feminization and secondary sexual characteristics, and also to prevent the osteoporosis. Second type, treatment for the second type of primary amenorrhea, that is eugonadotrophic treatment. So here it is important to see the healthcare provider to determine the cause of amenorrhea. The treatment here depends on the underlying causes. Sometimes it also may be due to lifestyle changes, can help if weight, stress or extreme physical activities is causing the amenorrhea. Other times it can also may be due to medications or oral contraceptives. Coming on to the next clinical type of amenorrhea, that is secondary amenorrhea, which is defined as amenorrhea of 6 months or more in a woman with previous normal menstrual patterns in absence of pregnancy. The etiology are physiological causes may be due to the pregnancy, lactation. The pathological causes are genital tract disorders, acquired obstructions of cervical canal, ovarian causes, nutritional causes. Pituitary causes may be due to the hypothalamus and thyroid, and other causes are diabetes, tuberculosis, renal disease, and severe anemia. Next, second type is dysmenorrhea. Second type of menstrual irregularities is dysmenorrhea. So dysmenorrhea, which is nothing but a painful periods, it includes severe menstrual cramps. So in this condition, it is not usually serious one, although it can sometimes can cause by infections, endometriosis, or even maybe due to a ovarian cyst. So painful periods can sometimes be eased by using a heating pads or taking a warm bath. Over-the-counter pain relievers can also help with the pain. So your healthcare provider might recommend the birth control pills or a birth control shot to make the periods less painful. Dysmenorrhea is again dividing into two main types, that is primary dysmenorrhea and secondary dysmenorrhea. The primary dysmenorrhea is the one that is not associated with any identifiable pelvic pathology. It is clear that the pathogenesis of pain is mainly attributable to the biochemical rearrangement. So it affects more than 50% of post-pubescent women in the age group of 18 to 25 years. Coming on to the second type, that is secondary dysmenorrhea, it refers to the one which is associated with presence of any organic pelvic pathology, that is fibroids, adenomyosis, and endometriosis. The varieties are, here the dysmenorrhea has been described under three main clinical varieties. First is spasmodic dysmenorrhea, second is congestive dysmenorrhea, third one is membranous dysmenorrhea. Spasmodic dysmenorrhea, which is nothing but it is more prevalent and manifest as cramping pains. Generally, it is most pronounced on the first and the second day of menstrual cycle. Congestive dysmenorrhea manifests as increasing pelvic discomfort and pelvic pain a few days before the menses begin. So thereafter, the patient rapidly experiences the relief in her symptoms. So the variety is common and it is mainly seen in the pelvic inflammatory disease or pelvic endometriosis. Third type is membranous dysmenorrhea. So it is a special group in which the endometrium is shed as a cast at the time of menstruation. So here the passage of the cast is accompanied by painful uterine cramps. The clinical features for dysmenorrhea is it has both local and systemic symptoms, and also it is apparently the result of increased level of prostaglandins in the menstrual fluids. So this results in uterine cramping, nausea, vomiting, backache, diarrhea, giddiness, and fainting. So if there is a increased level of prostaglandins in the menstrual fluid, it may lead to the uterine cramping, nausea, vomiting, backache, diarrhea, giddiness, and fainting. The investigations for dysmenorrhea is pelvic sonography, which is nothing but USG, followed by the CT scan or MRI if it is indicated. Then diagnostic hysterosalpingogram, sonosalpingography, and endoscopy. The treatment includes counseling, psychotherapy, and also we can able to modify the patient's prescriptions for her problem and alter the behavioral attitude. Medical measures and surgical interventions can also be planned. So the medical measures are analgesics, antispasmodics, prostaglandin synthesis inhibitors, oral contraceptive drugs which is administered cyclically can suppress the ovulation and also it is useful in relieving the dysmenorrhea. Next, pelvic endometriosis can also be treated with increasing doses of danazole or oral contraceptives. So these are the medical management for dysmenorrhea. Coming on to the surgical management, it also can be done only if it is indicated and if the medical measures is failed to provide the relief in the woman with secondary dysmenorrhea. So to treat the underlying pelvic pathology, we can go for the surgical management. So the diagnostic hysteroscopy followed by DNC, which is nothing but dilatation and curettage, excision of the polyp. Second surgical management is diagnostic laparoscopy followed by lysis of pelvic adhesions, myomectomy, drainage of chocolate system. Third one is hysterectomy in the elderly woman is the last resort, and we can go for the transcutaneous nerve stimulation is effective nearly about 45% of the cases who came with a complaint of dysmenorrhea. Coming on to the next condition. So first we have discussed about the amenorrhea, second is dysmenorrhea, third one is oligomenorrhea. So oligomenorrhea refers to infrequent menstrual periods or having a period only now and then. Like amenorrhea, oligomenorrhea is not a disease, but it is a symptom of a larger condition. For example, many women with PCOD have oligomenorrhea. In some women, the pattern of menstrual exceeds to cycle length exceeding 35 days without any impairment of their fertility. So the causes and findings on clinical investigations are similar to those of amenorrhea. Next condition is the polymenorrhea or epimenorrhea. Here, the women with polymenorrhea suffer from shortened cycles. This complaint is more frequent in adolescent girls and also in perimenopausal women. The etiology for perimenorrhea is the problem is actually not known, but in most of these women, the follicular phase of the cycle is accelerated, resulting in the shorter cycle. So the ovarian often appear hyperemic and also may contain the hemorrhagic follicles. So the excessive stimulation of gonadotropins causes frequent ovulation and menstruation. Next condition is abnormal uterine bleeding. So under this, the first sub classification is menorrhagia. So menorrhagia is an abnormally heavy and prolonged menstrual period at regular intervals. So the causes may be due to the abnormal blood clotting, disruption of the normal hormonal regulations of periods, or disorders of the endometrial lining of the uterus. So depending upon the cause, it may also associated with abnormally painful periods. We'll call it as a dysmenorrhea. Menorrhagia. So the normal menstrual cycle here, it falls between 21 to 35 days in duration, with the bleeding lasting for on an average of 5 days, and the total blood flow will be between 25 to 80 ml. A blood loss of greater than 80 ml or lasting longer than 7 days constitutes menorrhagia. It is also called as a hypermenorrhea. So the causes for menorrhagia, first is disorders of the coagulation. With the shedding of an endometrial lining's blood vessels, normal coagulation process can occur to limit and eventually stop the blood flow. Plus, blood disorders of platelets or coagulations or use of anticoagulant medications are therefore possible causes, although a rare minority of cases. Next is excessive buildup in endometrial lining. So periods soon after the onset of menstruation in girls, that is the menarche, and just before the menopause may in some women be particularly having heavy menstrual bleeding. Then hormonal disorders involving, that is as we have discussed the basic 5 factors which involved in the normal menstrual flow, the hormonal disorders. It involves the ovaries, pituitary, hypothalamus account for many cases. So the hormonal based treatment may also regulate effectively. The lining of the uterus builds up naturally under the hormonal effects of pregnancy. And in early spontaneous miscarriages may be taken for a heavier than normal period. During the women period, the endometrial lining, which is normally shed, never gets the signal to stop thickening. It keeps growing and shed irregularly. So due to the extra thickness, the bleeding is unusually heavy. So less frequently in this age group, too little estrogen causes the irregular bleeding. Most cases of hemorrhagic are due to the normal hormonal changes preceding menopause. Next causes irritation of an endometrium may result in increased blood flow, that is from infection, that is acute or chronic PID, or the contraceptive intrauterine device. It notes the distinction from the intrauterine system which is used to treat the conditions. Next one is fibroid. So fibroid in the wall of the womb sometimes can cause increased menstrual loss if they protrude into the central cavity, and so thereby increases the endometrial surface area. So these are the causes for the additional endometrial lining. The differential diagnosis for this condition is pregnancy complications. We may think it can also may be due to it can also be a ectopic pregnancy, incomplete abortion, miscarriage, or threatened abortions. So non-uterine bleeding, cervical ectropion or erosion, cervical neoplasia or polyp, cervical or vaginal trauma, ectopic vaginitis, foreign bodies. Next may be due to PID like endometritis and tuberculosis. The risk factors are obesity and ovulation, estrogen administration without progestogens. So prior treatment with progestational agents or oral contraceptives increases the risk of endometrial atrophy, but it will decreases the risk of endometrial hyperplasia or neoplasia. Coming on to the next condition, that is menometrorrhagia. So this is a condition in which a prolonged or excessive uterine bleeding occurs irregularly and more frequently than normal. So the causes for this condition is it can occur due to many several causes. Main thing is hormonal imbalance, endometriosis, uterine fibroids, or cancer. So it can lead to anemia in long-standing cases, and sometimes if there's a source, could be a anemia. Hypomenorrhea, which is also known as a scanty periods and spotting at periods, it's extremely light menstrual blood flow and lasts for less than 2 days. So it is an opposite of hypermenorrhea, which is more properly called menorrhagia. So the cause for hypomenorrhea is Ashman syndrome, intrauterine adhesions, of which hypomenorrhea or amenorrhea may be the only apparent sign. So degree of menstrual deficiency is closely correlated to the extent of adhesions. The causes for this hypomenorrhea is constitutional causes. So in some women, it may be normal to have a less bleeding during the menstrual periods. So less blood flow may be a genetic one. If it inquires or made, it may be found that woman's mother or a sister also have a decreased blood flow during their periods. So pregnancy can normally occur with this type of decreased flow during the period. The incidence for the infertility is same as a woman with a normal blood flow. So the constitutional scanty menstruation perhaps can be best explained by assuming the presence of an unusual arrangement or relative insensitivity of an endometrial vascular apparatus. In the uterine bleeding, the scanty loss sometimes means that the bleeding surface is smaller than the normal one. That is occasionally seen. When the endometrial cavity has been reduced in size during the myomectomy, myomectomy or other plastic operations on the uterus. However, it rarely indicates uterine hypoplasia because the presence of this condition in the uterus, which is responsive to ovarian hormones under activity, and also it manifests itself by infrequent rather than the scanty menstruation. Hormonal causes are the scanty periods can occur normally at the extremes of the reproductive life, just after the puberty or just before the menopause. So this is because ovulation is irregular at this time and the endometrial lining fails to develop normally. But the normal problem at other times can also cause scanty blood flow. Anovulation due to the low thyroid hormone level or high prolactin level, high insulin level, high androgen level, and problem with other hormones can also cause the scanty periods. So, the scanty menses can also occur after long-term use of oral contraceptives as a result of progressive endometrial atrophy. So this scantiness can also be occurs due to the nervous and emotional problem also. It is, we will be calling it as a psychogenic factors like stress due to exams or excessive excitement about the upcoming event may cause hypomenorrhea. Some factors may also suppress the activity of those centers in the brain that will stimulate the ovaries during the ovarian cycle to secrete the hormone like progesterone and estrogen. It can also result in the low production of hormones. So excessive exercise and crash dieting can also cause a scanty periods. So one of the causes of this hypomenorrhea is Asherman's syndrome, which is nothing but intrauterine adhesions, of which hypomenorrhea may be the only apparent sign. So the degree of menstrual deficiency here is closely correlated to the extent of adhesions. Diagnosis of this hypomenorrhea can be done with the help of a blood test, USG and other tests. So under the blood test, the common decreased flow of blood during the menses can be detected through the blood test. The test includes all levels of hormones like FSH, LH, estrogen, prolactin, insulin are important. And if a child or a woman is having PCOD, there will be a high level of insulin and androgen. Then coming on to the second investigation is USG. It can also be diagnosed through a USG. The thickness of the endometrium, size of the ovaries, growth of the follicles, ovulation and other abnormalities. Then the other tests like MRI are sometimes needed to find out the cause of scanty blood flow during the periods. The treatment is a significant causal abnormality is found, no treatment other than the reassurance is necessary. So treatment is a per cause in case of significant causal abnormality. Next condition is a intermenstrual bleeding. So it is a vaginal bleeding other than the postcoital at any time during the menstrual cycle other than during a normal menstruation. So bleeding between the periods, you will call it as a intermenstrual periods or bleeding. It can be associated with sexual intercourse or bleeding during intercourse or postcoital bleeding or may occur spontaneously. It is a frequently encountered symptom, 17% per annum. So bleeding between periods may be in the middle of a menstrual cycle, mid-cycle bleeding or mid-cycle spotting. Bleeding between periods is one of the example of gynecological abnormal bleeding. Women on pill may experience breakthrough bleeding. This is not strictly intermenstrual bleeding because the monthly bleeding experienced by those women taking the pill is correctly called withdrawal bleeding and is not spontaneous menstruation. Usually mid-cycle bleeding amounts are not more than the mid-cycle spotting. So bleeding between periods may be misinterpreted as irregular menstruation or irregular periods. When intermenstrual bleeding is reported, care should be taken to exclude the pregnancy bleeding or threatened miscarriage or any ectopic pregnancy. The causes for this intermenstrual bleeding is first is the physiological cause, which is nothing but hormonal fluctuation, that is 1 to 2 percentage spot around ovulation mid-cycle. Then iatrogenic are medically induced, combined oral contraceptive pill, progesterone only pill, contraceptive depot injections, intrauterine systems, Mirena, emergency contraception, then tamoxifen, then following smear or treatment of the cervix. The vaginal causes are vaginitis, bleeding uncommon before the menopause, infection. Cervical causes are cervical polyps, cervical erosion, cervicitis, then condylomata acuminata of the cervix, cancer. But bleeding is most often postcoital. Then other uterine causes are endometrial polyps, fibroids, adenomyosis, endometrial adenocarcinoma. Only 2% endometrial cancers occur before 40 years old. Risk factors: nullipara, diabetes, obesity, PCOD, chronic anovulatory cycle, use of tamoxifen for the treatment of breast cancer. Investigations are to determine that the bleeding is from vagina, not the rectum or in the urine. Any doubt can be eliminated by inserting a tampon which will confirm the presence of blood in the vagina. Then we can able to do a pregnancy test if it is appropriate. Then abdominal examination noting the presence and absence of any pelvic masses. Vaginal examination, that is speculum or bimanual examination looking for the obvious genital tract pathology. Other possible investigations are blood test, fasting blood sugar, clotting, thyroid function test, infection screening, bacteriology swab, then chlamydial swab. The management are, if gynecological cancer is suspected, refer urgently for investigation. Do not wait on the result of the smear test or be deterred by a previous negative result where clinical suspicion is high. Cervical erosions or ectropion may resolve if the OCP is stopped or following the pregnancy, can be treated conservatively. If treatment is desired, options include thermal cauterization and diathermy, cryosurgery, laser, or microwave therapy. Cervical polyps sent for histology. They are accompanied by endometrial polyps in about 25%. Further investigation like USG and hysteroscopy, particularly in older women, can be indicated. Then cervicitis, antibiotics dependent on organism involved, contact tracing and treatment of sexual partners, electrocautery of secondarily infected Namotheon follicles in chronic cervicitis. Summary: menstrual irregularities are common gynecological problems affecting the women of all reproductive ages. They may present as changes in the menstrual cycle, excessive or reduced bleeding, painful menstruation or absence of menstruation. Accurate history taking, physical examination, laboratory investigation, and imaging studies helps to identify the underlying causes. The management depends on the etiology and may include the lifestyle modification, nutritional support, medications, hormonal therapy, surgical interventions whenever necessary. Here, the nurses' care should focus on assessment, symptom management, patient education, emotional support, monitoring the treatment effectiveness, and promoting the reproductive health. Conclusion: menstrual irregularities are significant health concerns that can affect the woman's physical, emotional, and reproductive well being. Early diagnosis and timely treatment helps to prevent the complications and also to improve the quality of life. Nurses have an important responsibility in recognizing the abnormal menstrual patterns, providing compassionate care, educating the women about the menstrual health, encouraging the healthy lifestyle practices, and promoting the regular gynecological follow-up. Comprehensive nursing care contributes to better menstrual health and overall well-being. References: